Thank you for your introduction. Thank you for the invitation. The prototypes of joint diseases which are investigated are usually rheumatoid arthritis, osteoarthritis, gout. One of the interesting questions is how different and how similar are they? I show you some tissues in the joint, and one question which has not really been resolved so far in many aspects is what is the contribution of the specific tissues? What is the contribution of the synovia to pain? What is the contribution of bone? You see here terrible changes which you see in your practice and so on. And this is one thing which is not really that clear as we want to have it clear. Okay, one of the components which I think is at least strongly related to joint pain in many situations is in fact the synovitis. I just show you this one figure where we were able to investigate the pain intensity in patients who got knee joint replacement, and we have here a classification of the synovitis, high synovitis score, lower synovitis scores, and you see here, this is the COES scoring system. 0 means maximal pain, and you see here a very nice relationship between synovitis and pain. So I think among the many changes which may be involved in joint pain, including neuropathic components, the inflammatory component, at least in the synovia, is one important thing. It was already mentioned by Tony Dickinson that, of course, we have changes at many levels in the central and the peripheral and the central nervous system. And these are summarized here. Some of them were already mentioned. Usually, in many cases, practically all of the joint diseases show a component of peripheral sensitization. This is the main thing, I think, of many joint diseases. Then, of course, usually we have the spinal sensitization, including the glia activation. And then, of course, we have another story in the brain. We have, of course, the activation of the pain matrix with the relationship to the limbic system, as already shown by Tony Dickinson. We have the descending inhibition, which is reduced, which was already mentioned, and another thing which was not mentioned, which was reported repeatedly in the last years. The imaging studies showed some very strange changes in the cortex, that some of the cortical areas which are involved in the pain processing show some kind of atrophy. Nobody knows what that atrophy means, but it shows at least that there are some changes. I will come back to that later. I want to start with the peripheral level. What is a normal joint nociceptor? Yeah, this is the question which we asked initially. Yeah, what is a joint nociceptor look? What does it look like? In a normal situation, a joint nociceptor has a high threshold, so it's not activated by any innocuous stimuli. You can rotate the joint in the working range. It is not activated. This is a C fiber, a delta fiber, and you need, under normal conditions, really severe stimulus, a severe rotation, which is painful, to activate these nociceptive fibers. And the element of sensitization is that the threshold is really lowered so that you can activate the same nociceptors at low intensity with movements in the working range, with palpation. And this is the reason, the sensitization, why these stimuli, which are normally innocuous, normally painless, are becoming painful. This is the first process which is going on. Now, an interesting question, very important question also for therapy is, how is this sensitization produced? Now, this is one of the slides which I used to show these functional connections. You see here, as in the previous talk, ion channels, several ion channels for different stimuli. And you see here the ion channels for the action potentials. I want to go into detail in that. And you see here a lot of receptors on these sensory endings for compounds. And really the question is, why do we have so many mediators which may activate or sensitize the nociceptors? And I think we have to think about the different purposes of this chemosensitivity. I think many of these mediators may directly excite nerve fibers at a short latency and evoke action potentials and short-lasting pain. For example, hypertonic saline, which is often used as a stimulus by Lars Aret Nielsen, causes a brief pain. Also, we can excite these neurons by bradykinin, serotonin, glutamate, capsaicin, and others. These are very well-known compounds. And I think the interesting thing is they may or may not induce a short-lasting mechanical or chemical sensitization, but I don't think that they are very important for the problem of the patients. And then we have the mediators, on the other hand, which may sensitize sensory fibers for mechanical stimuli for a long time and evoke a long-lasting allodynia and hyperalgesia lasting hours and days. And I think two main classes of these long-lasting mediators with long-lasting effects are nerve growth factor and pro-inflammatory cytokines. So again, this is the picture. You don't need to understand everything. Basically, the sensitization, how does it work? We have here the ion channels, and their sensitivity can be changed by these mediators. And the question is, how long does the effect take, and what is the precise mechanism, of course? The nerve growth factor was mentioned several times. I don't want to go into many details. This is a very nice study, very important study, which shows the potency of nerve growth factor. This was the study where an antibody against nerve growth factor was injected once in patients with osteoarthritis pain. And you see for several weeks you have a reduction of this pain, very clearly showing that nerve growth factor seems to be one very important mediator, important for long-lasting sensitivity changes. We rather work on pro-inflammatory cytokines, and I think we have also changed our opinions about these cytokines. You have heard about these cytokines in the first talk. There is no doubt that they are very important for inflammation. I think that they are also important directly for the production of pain. I think there are two ways. Yeah? They can either produce inflammation, and then many things are switched on, for example, prostaglandin synthesis and so on, and this is the indirect way. But very clearly, many nociceptive neurons, they have receptors for these cytokines. So cytokines can also act directly on these neurons. And why we like this cytokine so much is shown in this slide. This is a recording from a C fiber in a joint, in a normal joint. You see here the nerve fiber recordings, action potential in one fiber. And then we can stimulate this joint by rotation. And we have here the response to the rotation. We have a very small response to innocuous rotation, and then we have a strong response to noxious rotation. When we inject in just in a normal joint, in an anesthetized rat, TNF-alpha, and you see that slowly the response pattern changes. So within few hours, the responses to innocuous and noxious responses show an increase. And this increase is really persistent. We recorded this at least for 3 hours. This is what I mean with long-lasting sensitization. We have never seen such a thing with prostaglandins or the short-lasting compounds. Yeah? So this is the reason why we believe that cytokines and eventually the nerve growth factor are totally different in their effects. They cause this long-lasting persistent changes. And by the way, this joint was normal and showing that this TNF is really some kind of pain mediator. So we have looked to several cytokines. I don't want to go in all the details. The TNF, for example, is interesting because it sensitizes the E delta fibers as well as the C fibers. And on the other hand, if we neutralize TNF in an experimental model, we can just reduce the mechanical hyperexcitability, even if the inflammation itself is not reduced at that time. I will show you in the next slide. This is our model which we use. This is antigen-induced arthritis. So if we have this model, we have hyperalgesia, which is shown here with the blue line, the reduction of the mechanical threshold at the knee joint, and slowly going up again. And this is the effect when we apply several times during this time etanercept, which neutralizes TNF-alpha. And the pathologists couldn't find a difference between these joints, the treated and untreated. But you see very clearly that this etanercept, along with any other treatment, reduces the hyperalgesia. So I believe there is good evidence that the cytokines themselves are involved in the pain production and the pain maintenance. And this has unfortunately also been shown in humans. A human study, they used TNF neutralization in patients with rheumatoid arthritis. And they found that within 1 day after application of infliximab, there was already a strong reduction of the pain response in these patients, although the response, the inflammation in the joints stayed the same for a very long time. So a very rapid effect. And I think if people are very happy if they get these inhibitors and they feel much better, it is mainly because the pain goes away. It's not so much because of the inflammation goes away. Later, of course, the effect of inflammation is, of course, very, very important. Yeah? But this shows very clearly the effect on pain of these cytokines. I don't want to go into many details. We looked to several cytokines. Interestingly, each of these cytokines has a different profile. They are not doing all the same. They're doing more or less the same on C-fiber responses, but you see very many differences in A-delta responses. So some cytokines may even reduce the A-delta activity and increase the C-fiber activity. And this is reflected to some extent what we see in the behavioral experiments when we neutralize these cytokines. So most effective in our hands was the TNF-alpha blockade, but then also the IL-6 is an interesting cytokine, although it takes much longer for the effects to come up. There are some reasons for that, but at the end, they are also antinociceptive. For example, IL-1 beta neutralization in our model did not have any effect, perhaps because it has this different effect on A-delta and C-fibers. And another one which has been a little bit in the focus for IL-17. This is also an interesting candidate. I know that it's not considered so important in rheumatoid arthritis, but in other forms of arthritis, it is quite important. What is the problem of this chronic sensitization? What I think is going on, if you have a drug treatment of a disease like a normal headache or so, you use a conventional analgesic drug, so if you are lucky, it reduces the pain and then it goes away. If you use NSAIDs in rheumatoid arthritis, you also get an effect, of course, but you never touch this underlying chronic sensitization, which is produced by nerve growth factor or by cytokines. And this is the reason why I believe that these things are chronic. And this 3-time daily medication with the NSAIDs just takes away the tip of it, but it does not change the underlying process. This is what I think. A second site in the periphery, which could be of importance, is in fact the dorsal root ganglia themselves. Here are the cell bodies of the neurons located. And what we and others found is that during arthritis, obviously macrophages invade these dorsal root ganglia. You see here macrophages. This is a normal situation. This is inflammatory model. And you see here really macrophages going on into these dorsal root ganglia. So obviously, far away from the joint, macrophages invade nervous structures. The question is, what are they doing there? Now, macrophages per se, you cannot tell what they do. You have to define the type. Macrophages can be classically activated. They are very pro-inflammatory. They can also be alternatively activated, M2 macrophages, and they are rather anti-inflammatory. And there are some types between the TNF-alpha activated macrophages. Now, of course, we were interested to see which type of macrophages do we find in our experimental model. And we characterized this. I don't want to go in many details. We tested several markers, and then we looked what type of macrophage could that be. And what we found is that in our hands, the macrophages which were in this dorsal root ganglia were the TNF-stimulated macrophages. Here, the TNF-stimulated macrophages. And what do they do? We studied the effect of these macrophages on neurons in co-cultures of neurons and macrophages. Again, I don't want to go in many details. The result is shown here. If the macrophages are stimulated classically, they activate neurons and they kill neurons. Fortunately, we don't find these macrophages in our model. We found these in the co-culture, these TNF-activated macrophages. They stimulate the neurons, but they do not kill them. The interesting question is, however, whether there are pain states and other models, and even the patients. Unfortunately, we don't know whether this happens also in patients. An interesting question would be, is a type of macrophage eventually important what type of pain is induced? Would it be neuropathic or inflammatory? But the interesting thing is that important processes go on far away from the joint, still in the peripheral neuron. Okay, I will go to the spinal cord. My topic is from peripheral to central. And this was already alluded to, the spinal sensitization, so I can make it brief. It was already mentioned that there is a lot of convergence of afferents from deep tissue and also sometimes from skin to common neurons. And the process of central sensitization was shown, and this is specifically the central sensitization by an inflammation in the joint. So expansion of receptive field was already shown. You see here, this is the response of a spinal cord neuron to noxious stimulation of the joint with a very restricted receptive field at the beginning. Then we induce an inflammation, kaolin and carrageenan, developing within several hours. And you see dramatically the changes, the responses increase to noxious stimulation here. And we have this expansion of receptive field after a few hours. These neurons is very sensitive to joint stimulation. You need only very weak stimuli, and it shows a receptive field which is expanded. And you have seen a similar slide. This is very nicely reflected in what people find with humans, that if you stimulate here near the joint and ask the patient, where do you feel the pain? Then these patients with a centratization, presumed central sensitization, say, yes, I feel the pain in a much larger area. I think this is a very nice correspondence of electrophysiology in animal experiments and humans. I think the concept is quite settled. How does it work? Probably, most likely, there are many synapses which are potent enough under normal conditions to activate the neurons, and there are other synapses more from the periphery which are under normal conditions not able to sensitize, to activate the neurons. When there is an input, sensory input from an inflamed area, this neuron becomes hyperexcitable. And then exactly happens what has been mentioned, that other inputs are sufficient to excite the neurons. So when you analyze the patient will not tell you probably, but you can test this. Yeah? The patient will say, I have knee pain, I have a problem in the knee, and then this is probably the expression of peripheral as well as central sensitization. But when you test then the patient, the pain pressure thresholds, as often shown by Lars Aret Nielsen and co-workers, then you have the idea that obviously also in the healthy tissue around, the threshold is reduced, and this is the expression of central sensitization. I think it can be tested whether a patient has a significant central sensitization. Okay, how does it work? Again, I don't want to go in many details. NMDA receptors, glutamate is the main transmitter. NMDA receptors are important. We have also contribution of neuropeptides which are released, CGRP, substance P are released, and we have an upregulation of prostaglandins in the spinal cord within a few hours, so they also contribute. So it's a really a multi-factor process. And more recently, there is some consideration how much glia activation plays a role. Now, glia activation has been detected some years ago as a response to many pain states. The main concept is shown here. We have the neurons, and parallel to that, the microglia and the astrocytes. And the point is that these microglia, they produce cytokines in the spinal cord. So how does it come into play? So we really believe that this glia activation is very important at the beginning already of such a pain state. When we compare, for example, the spinal sensitization under normal conditions during inflammation, and then if we compare this with blocking of the IL-6 cascade, the IL-6 response, we see a difference. So this is just a normal increase of activity during inflammation, and when we block the IL-6 cascade, this is significantly lower. So this shows that you need, obviously, these cytokines in the spinal cord already during the development of this inflammation. Now, in fact, we found that IL-6 is rapidly released in the spinal cord during peripheral inflammation. When you stimulate the joint and you monitor release of the IL-6, you find very rapidly IL-6 release in the spinal cord. And we were thinking, where are these IL-6 coming from? And we think that they are mainly coming from neurons in the spinal cord. Now, just a very recent paper of us showing some interaction between TNF and IL-6. The question is always, why so many cytokines? Do they interact? Is each cytokine working for itself? So what we found, just a brief notice, that TNF-alpha, which is also released to some extent in the spinal cord during peripheral inflammation, activates the neurons. They release the IL-6, and it activates the microglia cell, and this releases the soluble receptor. Both of these elements are important to activate the neurons. So I think the conclusion is that the cytokines in the spinal cord are very important, as well as the peripheral cytokines. Okay, let's move a little bit in the last minutes to the supraspinal sites. I have shown this before. Reduction of the gray matter, I have mentioned that people found a reduction of the cortical thickness. Nobody knows exactly what it means. Obviously, this is a response type to many chronic pain states, not specific for arthritis. You don't see here on this list even rheumatoid arthritis. I don't think it's really known whether it occurs in rheumatoid arthritis. It occurs in these pain states, which are listed here, for example, in osteoarthritis. You see here one example in ankylosing spondylitis, so this could be some kind of rheumatoid arthritis. So you see the same. You see just the difference between the control situation in the patients, and the patients with disease. So obviously there is a strong reduction of this cortical thickness. As I said, nobody really knows what it means. It has not been really found out so far, one must say. An interesting question is, are these changes reversible? And interestingly, if you can get rid of the pain, for example, by knee replacement, it seems to be reversible to some extent. So, and the people look to the same brains after some months, this atrophy has obviously disappeared. So this is the question then, is it a consequence of pain, or does it produce the pain? This question has also not been solved, but it shows very clearly that these patients with these chronic diseases have changes in the brain which are probably significant for the pain maintenance as well. Finally, it was already alluded to, the descending systems which are controlling to some extent the pain. And in fact, I think the first person who has detected this in humans is here in the room. This was Eva Kosek and her co-workers. They showed it already in a paper in 2000, that obviously the patients with chronic diseases, chronic pain diseases, have a reduction of these inhibitory mechanisms. And this has been also shown in many pain states now in the meantime. This is a meta-analysis of this on this conditioned pain modulation, that it's impaired in populations with chronic pain. And these are the results. They are very clear. So it seems to be a typical mechanism of chronic pain. Again, the question is, can it be restored if you can get rid of the pain? And this is obviously the case. If the patient becomes pain-free after hip replacement or knee joint replacement, then this inhibition is restored. Again, it's not that unreversible So we have to find the ways to get it reversible therapeutically. This is my last point I will briefly address. We are usually thinking about activation and of excitatory and sensitizing mechanisms that will produce the hyperalgesia and the pain. But I think it's also clear that we should consider the second part. That means in parallel, very often, we have an activation of inhibitory and desensitizing mechanisms. The brain tries to get control. This is, of course, part of the descending inhibitory control, tries to get the control about, over these things. Now, there are many possibilities for pain inhibition. Some are listed here. For example, you have a parallel activation of excitatory and inhibitory mechanisms. For example, somatostatin expression is inhibitory, opioid expression. We have also desensitization of excitatory sensitizing mechanisms, receptor and internalization. We have even, this is what we have found, the recruitment of inhibitory receptors by pronociceptive mediators. We found that one of these EP receptors for prostaglandin is in fact antinociceptive, and we have structural changes of innervation. The interesting point is, however, that these inhibitory systems are not totally used by the pain people. So this is the reason why if you give additional opioids, you get an inhibition, because obviously these systems are not fully used. And this is, of course, a potential also for treatment. So I think I'm finished with my time already. So I think I will stop here, and I hope I could show you really from peripheral to central that we have to consider all the levels, and that it's really clear that all the levels are changed. And when we think about pain treatment, we have to think about reduction of the excitatory, sensitizing mechanisms, but we should also not forget that many of these pain inhibitory systems are insufficiently driven by the brain, by the organism, and this is also one option where we can help the patients. Thank you for your attention.